love to know who you are and what you do.
My name is Hannah Gilmore. I am an anatomic pathologist, and what we do as anatomic pathologists are we look at tissue under the microscope. And I'm an anatomic pathologist who specializes in diseases of the breast.
And why did you decide to become a LearnLookLocate Medical Advisor?
I decided to become a LearnLookLocate Medical Advisor after meeting Cynthia Jordan and seeing her passion and really understanding her passion for teaching others about breast cancer. As a pathologist, I'm very involved in the care of breast cancer patients, but most of them don't know who I am, and that's totally okay. But I'm the doctor that gets the tissue after your surgeon or your radiologist removes it and looks at it under the microscope and says whether it's malignant or benign.
What does it feel like to be behind the scenes on such a powerful decision or diagnosis, if you will? What's it feel like for you?
It feels really good to be a part of such important patient care. It's so important to me, but at the same time, it's emotionally exhausting for me too. There's some days that I have diagnosed so many terrible cancers and so many terrible things. And, you know, even though I don't necessarily see patients in front of me in clinic, I know what that diagnosis means for them. So I'm glad to be able to provide that high quality care, but it can be emotionally draining at times.
What do you want patients to know about pathology when they are first diagnosed with breast cancer?
I would like patients to understand what pathology is and what we do. We look at your tissue, we interpret it, and we make the best diagnosis that we can for a patient. I think sometimes people think about the laboratory and the hospital and blood or tissue goes in and a result comes out, but there are people behind there helping to make that diagnosis. And I want patients to know how much we care about them and value making the right diagnosis.
Wow. What do you feel the newly diagnosed patient needs to know about pathology?
Newly diagnosed patients really need to understand what a pathology report means. So what is the disease that they have? If it's a benign disease, is it the type of benign disease that doesn't put them at a higher risk? If it's a cancer, what type of cancer? So what's the grade of the cancer, what the receptors are, the ER, PR, HER2, because starting to understand what all this information means is so important to a patient's care. And I want patients every patient should have a copy of her or his pathology report and make sure that they can go over that report with their doctor and understand what that means from them now and what that means for them in the future.
Do you feel that patients really understand what all the terminology means when smacked with this diagnosis? And do you feel, and this is just me asking you, a little plug-in for LearnLookLocate, you know, that there are ways to help people understand what all of this means?
So medical language and the language on a pathology report is very difficult to understand. You know, I sometimes, as a pathologist, when I read pathology reports from other places, it takes me a while to find all that information and make sure I understand what that report is saying. So I know so many smart people, so many talented people who know a lot about science and math and English and everything all about the world, who have a lot of trouble reading their pathology report. And that's why it's so important to read it and go over it with a doctor who can help you understand what all of that means.
Do you feel there's enough resources out there for patients to really grasp not only a diagnosis, but the terminology of what all this means?
It's very difficult for patients really to get a report and do a lot of research on their own, just because the terminology is so different than what we're used to. So any resource that's available that can help people understand what all these terms mean is really helpful. And that means that patients can really start digesting what their pathology report is.
So when I was diagnosed, Dr. Gilmore, my nurse navigator helped me to understand staging and grading. I'd love for you to talk about how important it is for people. I had a walnut-sized tumor, stage 1.
Mm-hmm.
And no, I'm sorry, stage 2B, grade 1. So
Mm-hmm.
in your beautiful, eloquent way, can you explain? I do post about this all the time, and I just don't feel like women even understand it.
But there are so many ways to describe clinically and pathologically what a cancer means. So there's clinical staging, 1A, 1B, 2A. Also, those are clinical. That means how big the cancer is, has it spread to lymph nodes. So those are terms that you would hear, a lot of clinicians talk about. For pathology, we use some different terms. We have what's called pathologic staging. So we'll give, sometimes you've heard of, you see on your surgical excision, T, N, and M, you have a T1, N1. Those are the pathology, that's the pathology staging that we talk about. That describes a lot of the characteristics of the cancer. But there are also a lot of other things that we describe in our pathology report. We talk about the histology. That means what type of cancer it is. Most breast cancers are invasive breast cancers are called invasive ductal carcinomas, but there's some other types as well, invasive lobular carcinoma, mucinous carcinoma. That's the histology, or the pattern of the cells under the microscope. Aside from the histology, we give it something called a grade. Breast cancers are graded as 1, 2, or 3. 1 is the lowest grade. They look most like normal breast cells. 3 is the highest grade and tends to be the most aggressive because the cancer cells really don't look much like they're the normal cells that they originated from.
How can you help a patient feel empowered by that, the knowledge that you just said? So as someone like me, I'm like hanging out near stage 3, but yet I'm stage 1. I mean, I'm grade 1. And I don't know if there's a better way to ask this question, but I sleep at night knowing I'm grade 1.
Yeah. The diagnosis of breast cancer is so overwhelming, and there's so many details that patients learn in the beginning. And sometimes patients are so in shock that they have a difficult time understanding what all the things on their reports, their pathology reports, their radiology reports, all these things really mean. But it's really important to take the time to understand that, because and to ask questions of your clinicians, ask of navigators, all sorts of people are there to help you understand, because when you understand, what you're doing is you're starting to develop more control over your situation, and you can really be part of your planning. And so I think it's really important that all patients understand the reports that they're given.
Wow, that's awesome. What would you like to say, because you are behind the scenes, about so many diagnoses? This is where the compassion from what you do for, like Dr. Singh is like, he did a whole thing on reoccurrence and how young women are getting this. Can you speak to the state of what's going on with this disease and from your heart, what you feel is going on from what you see?
So many women and a fair number of men are diagnosed with breast cancer. And there's such a range. It breaks my heart to see young women diagnosed with really aggressive breast cancers, but it breaks my heart to see anybody diagnosed with any disease, any type of breast cancer, even older women with a good prognosis. I just feel so bad whenever, I tell my trainees that when I work with them that I much prefer to diagnose benign things than malignant things. And it's a good day when all my breast biopsies are benign, and it's a bad day when all of my breast biopsies are malignant.
Yeah. What would you like to say regarding your thoughts on why so many diagnoses? I always like to draw attention to pageants, and lobular, and DCIS, and all of that. Can you talk a little bit about that so that the awareness factor behind where it relates in pathology is be interesting to bring that up?
There are really a lot of different types of breast cancer. Breast cancer is not one disease. It's really a whole lot of different diseases. In my mind, I like to divide things up into two categories of breast cancer. We have our non-invasive breast cancer, or DCIS. The long name for it is that DCIS stands for ductal carcinoma in situ. And it means that they're cancer cells, but they're still inside the ducts of the breast and they haven't been able to get out and to invade into tissue. DCIS is most commonly found from screening mammography because these cells inside the ducts, they become necrotic, they die, and they calcify. And so that's usually how they show up, as on screening mammograms. And sometimes if they involve the nipple areolar complex, that's something known as Paget's disease. Fortunately, with screening mammography, we don't see as many cases of Paget's disease as we used to. The more common type of breast cancer is invasive breast cancer, and these are when the cancer cells invaded outside, invaded through the ducts and to the surrounding tissue. And these are more dangerous because once these cancer cells invade, they have the ability to metastasize. They can go to lymph nodes, or unfortunately, they can go to other sites in your body.
This is so brilliant. You have no idea. I'm so happy you're doing this. Can you tell me what cancer looks like under the microscope?
Cancer can look like a lot of different things under the microscope. In pathology, kind of our way of looking at the world is our glass slide. And when we make a glass slide of tissue, our stain that we use is called something called an H&E. And an H&E turns our world into pink and purple. And these pink and purple colors are what we see under the microscope. And we can look to see what's normal, what's not normal. And if it isn't normal, like a cancer wouldn't be normal in the breast, that's, these two cancer cells that are invading outside the ducts, we can see that. But breast cancer can look like a whole lot of different diseases.
Why can't, and this might be my last question, unless you have other things, but why can't we feel, this is way out there, but I've always wanted to know, I never felt sick. Why is it that we can't notice or feel that these cells are misbehaving? Why, if it weren't for you, we have no real way of knowing that we have cancer. So how, and that's just a wild way to ask a question. I'm not even sure.
Yeah. Well, cancer can present in a lot of different ways. For breast cancer, most of the time, breast cancer is found on screening mammography, usually because the cancers are small, and they're small enough that it's hard for someone to palpate or feel in his breast. But sometimes cancers grow quickly. Sometimes cancers don't show up on some of these mammograms very well, and they present with patients actually feeling them. And the fact that you can feel them and there's an abnormal lump is a sign of cancer, because these cancer cells secrete all these different molecules that make the tissue around them hard as they invade, and that's what causes the mass lesion in the breast that you can feel.
Ah, I think I sort of knew that. My boyfriend keeps telling me they're just cells that keep multiplying, and because they can't slough off and be normal, they kind of, can you explain a little more, for my own curiosity, do they harden against each other? Like, can you talk to that?
Well, it depends. So cancer, when I think about the best way of describing cancer, cancer occurs when there is an alteration or a mutation in a cell of the body. And it's a mutation or alteration that means that cell can't keep itself in check. That cell does not know how to stop growing. And most of the normal cells in our body do. But when you have cancer, that cell can't stop growing, and it keeps on growing and growing and growing till it causes problems. And in the breast, that might be a big lump. In other parts of the body, that may be something else. That might be, unfortunately, patients who present with pancreatic cancer, sometimes it blocks the ducts and they develop, really a lot of jaundice or turning yellow. So, the way cancer presents is different in different parts of the body, but they're all characterized by the fact that they just don't know how to stop. They can't turn themselves off from growing.
So if somebody, like I had cancer in my sentinel node and they think they got it out, so can you explain, I could talk to you for hours, but I'm going to be respectful of your week off because this is so interesting to me. I can't believe it. Can you explain how, if a cancer cell, because all these women on Instagram are so afraid of reoccurrence, can you explain what happens when that one little cancer cell is just floating around? Because God knows if that's happening to me, whatever, you know where I'm going. Like, how does a cell leaves the tissue, floats around, and how is it that we don't know right away? And, does it just kind of float around? I mean, what's happening?
Cancer itself is really invasive cancer is a systemic disease. And we know through surgery, whether in the breast it's a lumpectomy or a sentinel node, we get out most of the cancer. They're very well, in some patients, there are a few little cells floating around in there. And that's why, we always consider cancer a systemic disease. And so some patients need chemotherapy to try to, get rid of all those little tiny cells that are floating in their body. For some patients, there are a lot of breast cancer patients with ER positive, HER2 negative disease, where they know that chemotherapy won't help them keep those little microscopic cells in check, but we know that hormonal therapy will. So those are women who would benefit a lot more from, systemic hormonal therapy to kind of fight off all those little microscopic deposits that we might not know where they are. So that's always a very important part of treatment, because really invasive cancer is a whole system, a whole body disease. And we need to treat the whole body. We need to treat locally to make sure we get the biggest areas out. But it requires treatment of the whole body.
But we don't know we really never know if a cell, and how long, so when people have a reoccurrence 7 years later, where is the cell going, Dr. Gilmore? Is it just kind of hanging out? It doesn't, this is what I don't understand.
I think a lot of people, there is a lot of speculation, but I don't think that anybody really fully understands the biology, where those tumor cells are hanging out, why all of a sudden, after so many years, they would come back. It's a mystery. A lot of good ideas and a lot of good research to try to figure it out, but it's still somewhat of a mystery.
And one last thing, I promise, because I had this on my right breast, was atypical hyperplasia. Can you explain what that is and how anyone in their right mind would know that they have that? I was told not to get the right breast off. That's not the one that had the tumor. And then after I got it off, only until the pathology report was read could they say, good call.
Well, these are great questions. So I've spoken a lot about malignant breast disease, but there are a lot of benign breast diseases as well. The way we like to think about them are the breast diseases that don't have atypical cells and the breast diseases that do have atypical cells. There are two types of atypical, or what we call atypical hyperplasias in the breast. There's atypical ductal hyperplasia, and there's atypical lobular hyperplasia of the breast. Usually atypical ductal hyperplasia is found, they're often associated with calcifications, but sometimes they're seen, sometimes they're part of a biopsy for something else as well. And we'll see the radiologist target them on core needle biopsy. And those are important to recognize when you have atypical ductal hyperplasia. The standard of care would be to have that, if you find it on core needle biopsy, to have it excised, just to make sure that there isn't anything worse around there. And hopefully there isn't anything else worse than the atypical hyperplasia around there. But it's important to know, because women who have atypical ductal hyperplasia have about a 4 to 5 times risk of developing breast cancer. So that automatically puts women into a high risk category. There's another type of atypical hyperplasia that's known as atypical lobular hyperplasia. This is getting into, advanced level breast pathology here.
Okay.
So, I think, for patients who have atypical lobular hyperplasia or ALH, maybe they've gone over this with their doctor. But again, it's really a risk factor. And usually atypical lobular hyperplasia, we find incidentally for something else. Usually that doesn't show up as something that on screening mammography. But it's important to know that you have those diagnoses, because if you have those diagnoses, then you're high risk, and you need to know that. And many physicians will have a high risk clinic, or they'll put you on an increased screening protocol because that is a risk factor for developing breast cancer.
One last closing statement that that you would like to say to, again, the face, you are face to these women, it's so lovely to have someone behind all of it. And just, kind of just, if you could just say something, a closing remark towards Learn, Look, Locate in education, and if you don't mind, and that, again, how important it is. And any other thoughts that you have?
So I think as a pathologist, and particularly a breast pathologist, I would like patients to know that there's someone in the lab sitting behind the microscope, really looking at the tissue, making the best diagnosis, knowing that there are patients behind there, and we take our jobs really, really seriously. And I might not have a patient sitting right in front of me, I feel that way when I'm looking at the microscope, knowing about what the implications of the diagnosis that I'm making, and what that means for the person who's going to show up in clinic and talk about that with her or his doctor. So I really would like everybody to know that. I also think it's really important for people to know what their reports mean, and know what all the medical terminology means, and have a really trustworthy place to find this information. You put in terms on Google and you don't know what comes up, and you don't know who's behind all those sources. So it's really important that as you look for information, if you have the diagnosis, that that you feel empowered to talk with your clinicians, and where to go to find more information. I think that that's really important.